Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Daniel Reynolds. In this episode, we will focus on rapid start of antiretroviral therapy for patients who are newly diagnosed with HIV. Which regimens are recommended? How should you handle rapid start in patients who have previously received PrEP? To answer these questions, I'm joined by Dr. Daniel Kuritzkes from Harvard Medical School and Brigham and Women's Hospital in Boston, Massachusetts. For more information about Dr. Kuritzkes and this program, and to follow along with the slides, please visit the links in the show notes for this episode. Now let's get started and hear what Dr. Kuritzkes has to say about rapid start of antiretroviral therapy.
Highlighting here the recommended regimens for a rapid start of antiretroviral therapy from the two sets of U.S. guidelines, the DHHS guidelines and the IAS USA. A rapid start meaning starting somebody immediately or within a day or so after diagnosis, really before you have the ability to obtain any baseline laboratory test results. Neither a bictegravir or dolutegravir based regimen is recommended, but the addition of a boosted darunavir regimen, either as a single tablet formulation or as a multiple tablet formulation, is also recommended because of its potential activity against drug-resistant viruses while you're awaiting the results of baseline drug resistance testing. In this scenario, it's important to point out that two drug regimens like dolutegravir 3TC and non-nucleoside RT inhibitor-based regimens are not recommended, nor are abacavir-based regimens because you won't yet know the HLA-B5701 status of the patient. Now, there may be unique considerations in a patient who has a history of PrEP, and here the concern, of course, is if somebody was on TAF or TDF-based PrEP, they may have developed resistance to either tenofovir or to lamivudine and emtricitabine. But in those circumstances, you would obtain a genotype and go ahead and initiate therapy. It's still perfectly permissible to move forward with a dolutegravir or bictegravir-based regimen together with FTC or 3TC and TDF or TAF, given the demonstrated activity of these regimens, even in the setting of nucleoside resistance. By contrast, if a patient has been on a injectable cabotegravir PrEP, then there is concern about resistance to integrase strand transfer inhibitors. And although you can still initiate treatment, here treatment should be most likely started with a boosted darunavir regimen until the results of genotyping are back. And then if there is no evidence of cabotegravir or INSTI resistance, then it would be okay to switch the patient to a dolutegravir or bictegravir containing regimen. These data are relatively new, presented at ID Week in the fall. Long-term follow-up from the START study. As you'll recall, the START study was a randomized trial that compared immediate versus deferred antiretroviral therapy in people with CD4 counts over 500. It demonstrated the benefits of immediate initiation of antiretroviral therapy. Here at the 5-year mark, there's still a significant benefit for early treatment as opposed to waiting until the CD4 counts have declined.
Thank you very much to Dr. Kuritzkes, and thank you to our listeners for joining in. As a reminder, to view the full Contemporary HIV Treatment and Prevention 2023 program on the Clinical Care Options website, and to access the slide set for Individualizing ART, What Do Patients Want?, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.